Antiarrhythmic drugs are classified by Vaughan Williams classification system into four main classes based on their mechanism of action. Class 1 are sodium channel blocker, Class 2 are beta blocker, Class 3 are potassium channel blocker, and Class 4 are calcium channel blocker. Now, before we break down each class, we need to understand the fundamental process that these drugs modify, the cardiac action potential. There are two types of cardiac action potential. First, let's talk about the action potential in contractile cells. These make up the bulk of the heart muscle, the atrial, ventricular, and Purkinje fibers. Their job is to contract and pump blood. Unlike some other cells in the heart, they lack automaticity, which means they need to be stimulated by another cell to fire an action potential. The action potential in these cells is called the fast and long action potential. It has a unique, distinct plateau phase. This is really important because it prolongs the contraction and prevents the heart from going into a continuous, uncontrolled contraction. Class 1 and 3 drugs, which are the potassium channel blockers, primarily work on the fast response cells. We're going to talk about this later in the video. Now, let's look at action potential by the pacemaker cells. These are the spark plugs of the heart, found in the SA node and AV node. These cells are responsible for automaticity of the heart, meaning they can spontaneously generate their own action potentials without external stimulation. The action potential in these cells is known as the slow and brief response action potential. Notice the key differences from the fast action potential. There is no phase 1 and phase 2. There is also no notch and no distinct plateau phase. Class 2 and Class 4 drugs work on these slow response pacemaker cells. They slow down the heart rate and reduce conduction by affecting the influx of calcium ions. I will explain this later in the video. We're looking first at the slow response action potential, the one responsible for the heart's automaticity. Unlike the fast response cells we discussed, pacemaker cells in the SA and AV nodes do not have voltage-gated sodium channels. Their action potential is primarily driven by the movement of calcium and potassium ions. This action potential has three key phases: a slow upstroke, phase 0, a repolarization phase, phase 3, and a spontaneous depolarization phase, phase 4. Phase 0 is the depolarization phase. The depolarization phase is much slower than the fast action potential because calcium ions move into the cells slowly through slow L-type calcium channels. This slow movement creates the slower upstroke, which is less steep than phase 0 in fast action potential. Next is phase 3, the repolarization phase. Here, the calcium channels close and potassium ions move out of the cell, bringing the membrane potential back down to its resting state. Phase 4, the spontaneous depolarization phase, is the most important phase in slow action potential as it is responsible for heart's automaticity. The SA nodal cells are leaky. During phase 4, sodium ions leak into the cells, and we call this funny current, which is annotated by if. This gradually depolarizes the cell until it reaches a threshold potential. Once this threshold is reached, it activates the L-type calcium channels. This is how SA node makes transition during phase 4 back to phase 0. This cycle repeats continuously, generating natural, steady heart rhythm, which is what gives pacemaker cells their automaticity. An extra thing to take note: the larger the funny current, the faster the conduction rate. The smaller the funny current, the slower the conduction rate. Now, we're going to talk about the fast action potential. At resting potential, the electrical charge inside the cell is around -90 millivolts. The process starts with phase 0, depolarization phase. Fast sodium channels open, and a rapid influx of positive sodium ions rushes into the heart muscle cells. This makes the inside of the cell more positive, creating a sharp upward spike on our graph. The inward flow of sodium ions stops once the electrical charge inside and outside the cell becomes equalized. Moving on to phase 1, initial repolarization. The fast sodium channels close. Some potassium channels open. This causes a slight initial decrease in the cell's charge as some potassium ions flows out of the cell. This brings us to phase 2, the plateau phase. This is the critical part of the cardiac action potential. Calcium channels open, allowing a slow influx of positive calcium ions into the cell. At the same time, potassium continues to flow out. The balance between the influx of calcium and the efflux of potassium keeps the cell's charge relatively stable, creating this plateau. This long plateau is what allows the heart to contract and relax in a coordinated manner, preventing it from going into a sustained contraction. Following the plateau, we enter phase 3, the repolarization phase. Here, the calcium channels close, but the potassium channels remain open. A significant amount of potassium now flows rapidly out of the cell, causing a sharp drop in the cell's electrical charge. This returns the cell's charge to its negative resting state, leading us to phase 4, the resting membrane potential. This is the state where the cell is at rest, waiting for another stimulus to begin the entire cycle again. Now dive back into antiarrhythmic drug class. We will first look at the Class 1 sodium channel blockers. These drugs are divided into 3 main subclasses: Class 1A, Class 1B, and Class 1C. Let's start with Class 1A. We have quinidine. There is a few things to be aware of. Quinidine potentially causes digitalis toxicity, especially during hypokalemia. It also carries a significant risk of QT prolongation. Then prokinamide. A key side effect to remember for prokinamide, especially with long-term use, is the risk of a lupus-like syndrome. Symptoms are such as flu-like symptoms, joint and muscle pain, chest pain, and skin rashes. Then we have disopyramide. A major side effect of disopyramide is its antimuscarinic effect, so we should avoid using this drug in conditions like glaucoma or prostatic hyperplasia. We should also avoid using it in patients with heart failure, as it can worsen their condition. Next is Class 1B. The 2 main drugs here are lidocaine and mexiletine. Unlike the Class 1A drugs, these don't have a significant effect on the QT interval. They are often used acutely in a hospital setting to treat ventricular tachycardia or other life-threatening arrhythmias. The 2 main drugs in Class 1C are flecainide and propafenone. These drugs should be avoided in structural or ischemic heart disease. Using them in these patients can actually increase mortality. They are also contraindicated in patients with severe asthma or COPD, especially with propafenone, due to its mild beta-blocking properties. Talking about mechanism of action of Class 1 drugs, the primary effect is to block fast sodium channels in the heart. This action directly affects 2 things during the cardiac action potential, which is first, the slope of phase 0, or depolarization phase. Class 1 drugs slow down the activation of fast sodium channel, which in turn slows down the rate of depolarization in phase 0, leading to flattening of the slope of phase 0. This will also reduce the amplitude of the action potential. From the graph, you can see lower peak amplitude than the normal curve, and the slope of phase 0 become less steep. The decrease in this slope will affect a slower conduction velocity of the heart. The second thing it affects is the effective refractory period, or ERP. This is the period when the heart muscle can't be stimulated again by a stimulus. By blocking the sodium channel, Class 1 drug can affect ERP by affecting the rate of repolarization, which depends on how fast sodium channels to recover from inactivation and become available to generate a new action potential. Rate of repolarization also affect the duration of action potential, or APD. The increase in ERP shifts the repolarization curve to the right. Now, these 3 subclasses have different level of sodium channel blockade and affect the effective refractory period differently. Class 1A cause a moderate sodium channel blockade, hence a moderate effect on the slope of phase 0. You can still see that the slope of phase 0 becomes slightly less steep. It also increases the effective refractory period by delaying repolarization, causing the phase 3 curve to move to the right. This makes the heart tissue less excitable for a longer period. Class 1B drugs are weak sodium channel blockers. The effect on slope phase 0 is mild. Unlike Class 1A, they decrease the effective refractory period. The phase 3 curve moves to the left. Class 1C drugs are the strongest sodium channel blockers. They cause a very significant decrease in the slope of phase 0 in comparison to the other two. However, they have little to no effect on the effective refractory period, so you can see the phase 3 curve remain the same. This is a comparison graph of three subclasses. It is obvious that the stronger the sodium channel blockade, the less steep the slope of phase 0. To summarize, all class 1 antiarrhythmic drugs work by blocking fast sodium channels in heart muscle cells. This will slow down conduction velocity and help stabilize the heart's rhythm. Class 1A are effective in treating both atrial and ventricular arrhythmias. Example of atrial arrhythmias are atrial fibrillation and atrial flutter. An example of ventricular arrhythmias is ventricular tachycardia. Class 1B are particularly useful for acute ventricular arrhythmias. Class 1C, the most potent subclass, are mostly reserved for the most life-threatening ventricular arrhythmias. Move on to Class 2 drug, the beta blockers. We have propranolol and metoprolol. These are two of the most widely used beta blockers. And then there's esmolol. It is often given in acute or emergency cases due to its fast onset and a remarkably short half-life, which allows it to titrate rapidly when necessary. Another common one is atenolol. Now, like any medication, beta blockers come with potential side effects. Some of the common ones are bradycardia, hypotension, bronchospasm, and myocardial depression. When talking about the mechanism of action, beta blockers work by blocking beta receptors, which are part of the sympathetic nervous system's fight or flight response. This action counteracts the effects of stress hormones like adrenaline, which can cause the heart to beat too fast. Now let's see how they work on a cellular level. Beta blockers primarily target the slow response action potential in pacemaker cells. It affects two key parts of action potential. First, it decreases the slope of phase 4 depolarization. Second, it prolongs the repolarization in phase 3. Class 2 drug also increased the PR interval on the ECG. Remember that the funny current in phase 4 is what causes spontaneous depolarization. By blocking beta receptors, these drugs reduce the slope of phase 4, meaning the cell takes longer to reach the threshold for the next action potential. This in turn inhibits sympathetic stimulation of receptors in the SA and AV nodes, resulting in decreased automaticity, which refers to heart ability to generate impulses and trigger heartbeat without external stimulation. This will result in a slower heart rate. Also, by prolonging repolarization, Class 2 drug decrease incidence of re-entry, which can cause abnormal electrical activity that are common in arrhythmias. When we talk about cardioselective beta blockers, we're primarily looking at their effects on the beta 1 and beta 2 receptors. Cardioselective beta blockers have a much stronger effect on the beta 1 receptors, while they have little action on the beta 2 receptors. The beta 1 receptors, when blocked, lead to a decrease in heart rate and a decrease in contractility. This makes them highly effective for rate control, especially in cases of supraventricular tachycardia. On the other hand, the beta 2 receptors, when activated, primarily cause vasodilation. Since beta blockers have little action on these receptors, this effect is not a primary concern for cardioselective beta blockers. Now let's move to Class 3 drugs, the potassium channel blockers. The most famous of these is amiodarone. It is a very potent drug with a unique mechanism. Interestingly, amiodarone isn't just a potassium channel blocker. It's often called a broad-spectrum drug because it also blocks beta receptors, sodium channels, and calcium channels. This multi-channel effect makes it incredibly effective for a wide range of arrhythmias. Amiodarone is often used to maintain a normal heart rhythm after a procedure called electrical cardioversion, which is used to reset the heart's rhythm. For this purpose, it is typically used for a period of 4 weeks before and 12 months after the procedure to increase the chances of long-term success. Dronedarone was developed to be a safer alternative to amiodarone. It is a derivative of amiodarone, but without the iodine molecule. This change was meant to reduce some of the severe side effects associated with amiodarone. While it may be safer, studies show that dronedarone is less effective than amiodarone. It's also known to have its own set of risks, including hepatotoxicity and an increased risk of heart failure. Sotalol is a unique medication because it has a dual mechanism of action. It functions as both a Class 3K Feist channel blocker and a beta blocker. This dual activity is important because it combines the antiarrhythmic properties of potassium channel blocker with the heart rate slowing effects of beta blocker. However, like all class 3 drugs, sotalol carries a significant risk of QT prolongation. Because of this risk, patients taking sotalol need to be monitored closely. So how do these drugs work? They primarily act on the fast response action potential in contractile cells. They block the potassium channels responsible for repolarization, causing a delayed repolarization. By blocking the outward flow of potassium, they significantly prolong both the effective refractory period, ERP, and action potential duration, APD. Think of it as putting the heart cell on pause, making it less excitable and less likely to fire an abnormal beat. In summary, it blocks potassium channel from leaving the cell in phase 3 that lead to delayed repolarization and lengthened ERP. This would prevent re-entrant arrhythmias, where an electrical impulse gets stuck in a loop. This helps to reduce excitability of the cells and reduce abnormal heart rhythm. This makes them effective in treating broad spectrum of arrhythmias such as supraventricular and ventricular tachyarrhythmias. But remember that they all cause QT prolongation, which lead to life-threatening torsades de pointes. Class 4 drugs, calcium channel blockers. The two main drugs you need to know in this class are verapamil and diltiazem. These drugs are often referred to as rate-limiting calcium channel blockers because their primary effect is to reduce heart rate and contractility. Now, a couple of key cautions to keep in mind when using these medications. Caution 1. Be very careful when combining them with beta blockers. Both classes of drugs slow the heart rate and reduce contractility. Using them together can lead to a dangerously slow heart rate, bradycardia, or even heart block. Caution 2. You must avoid using these drugs in patients with heart failure. Because they reduce the heart's contractility, they can worsen the condition in patients who already have a weakened heart muscle. Class 4 drugs can commonly cause bradycardia, hypotension due to vasodilation, and constipation, which is a frequent and bothersome side effect, especially with verapamil. Class 4 drugs work by targeting L-type calcium channel found to the sinoatrial node and the atrioventricular node. It decreases the slope of phase 0. It also causes a prolonged repolarization at the AV node. As a result, it increased effective refractory period. This also increased PR interval on an ECG. This corresponds to the delay of conduction of electrical signal from atria to ventricles. In simple terms, class 4 calcium channel blockers block L-type calcium channels. This will slow down SA and AV conduction, leading to decreased automaticity, and stop abnormal fast heart rhythms to achieve rate control. Class 4 drugs are particularly effective for treating supraventricular tachycardias, atrial fibrillation, and atrial flutter. There are also other antiarrhythmic agents that fall into their own category. First up is adenosine. Adenosine is particularly useful for acute situations because of its very short duration of action, typically lasting only a few seconds. It works by binding to adenosine receptors. This will decrease cyclic AMP, results in opening of potassium channels and closure of the calcium channel. Opening of potassium channels causes hyperpolarization of the AV nodal cells, while closure of calcium channels can inhibit calcium entry. Both effects slow down AV node conduction, which ultimately results in a slow heart rate. Adenosine is most effective for treating supraventricular tachycardia. Next, we have digoxin. This medication is effective for managing arrhythmias in sedentary patients with congestive heart failure. Digoxin works by blocking the sodium-potassium pump. This, in turn, activates the sodium-calcium exchanger, which leads to an increase in intracellular calcium. This leads to an increased myocardial contractility, which allows for rate control. It is particularly useful for atrial fibrillation. Finally, let's look at magnesium sulphate. The exact mechanism of action for magnesium as antiarrhythmic is not fully understood. However, what we know is magnesium sulphate is effective for treating torsades de pointes, digoxin-induced arrhythmias, and for hypomagnesemia-induced arrhythmias. Thanks for learning with Pharmacademy by Luna. See you in the next video.